Well, here we go, episode 2, Cardiovascular Emergencies, chapter 17. I went ahead and changed the microphone. The last one sounded like maybe I recorded it in the bathroom of a nightclub, so hopefully this will be better, but who knows. So let's carry on here. Management of an adult cardiac arrest. So most patients with cardiac arrest, they have evidence of prior heart disease. So a lot of that can come from atherosclerosis, congestive heart failure, a prior MI, a lot of different things. But what can also come from, though, can be just these acute things. So electrocution, drowning, trauma, drug overdoses, asthma, anaphylaxis, a lot of different things can cause this. So it's not going to be every time you go on a full arrest, it's not going to be someone that has an extensive cardiac history, obviously. And many times there's going to be no warning before the event. You know, they had no signs and symptoms and no real reason to think that this could possibly happen. So what we talk about is this with paramedics, and the best way to deal with this, the stress of a cardiac code, is to practice so that the team works very well together. So much like we talked about patient assessment with having that systematic approach, these codes should be the same way, especially if you work for a service to where you're able to work with the same partner for some time. You guys should be able to get very good at managing these kinds of codes. Because it does require a couple of things. It requires, obviously the knowledge and then the ability of several ALS skills and at least one good provider. So, the one thing that I'll ask is that you use an orderly and systematic approach that's going to be rehearsed repeatedly in a team setting. So how do we accomplish that here? Well, we're going to go over megacode after megacode after megacode. And that's where these labs become so important, because this is the foundation. This is the initial training that we're getting. So we really need to become good at this as we're building this skill. So when we think about this as paramedics, you look at this as an EMT when you're running calls, or as a new paramedic, you start thinking about this. How will I do this? Well, you see here, we're going to talk about when we approach the scene, all the different things that we're going to take. So, depending upon what you have and what you need, defibrillator, obviously, your portable O2 you'll want, your airway management kit. Most of these other things you may have just in your ALS bag or ALS kit, whatever. But you may not need to take everything, but many times, you need a good suction unit, and of course your airway stuff and your dope, your drugs and your IV stuff. So the goals of emergency medical care, we got a couple of big things, and we're still talking about just the cardiac arrest. So that's our goal or that's what we're talking about, the goal for managing a cardiac arrest. So number one would be the return of spontaneous circulation, or you'll hear it, if you haven't already, you'll hear it referred to as ROSC. Also, though, within that, we want to preserve as much neurological function as possible, because it's not that cool when we were able to be a part of saving someone, yet all they do is get shipped downtown to a ventilator hospital, and they lay there with no neurological function. So we need to make sure that we're good at this. We need to make sure that we're doing things in a timely manner, that we're sticking with the algorithm or the protocol or the plan or whatever. So begin emergency care immediately upon discovering pulselessness. We want to make sure that they are staying hypoxic as little time as possible. We want to make sure that we're getting good compressions, we're circulating that blood, as well as we're trying to unload some oxygen as soon as possible. So when is it right to withhold CPR? Maybe some of you guys are thinking. So there's a couple of things here, and a lot of this now is going to depend upon your local protocol. So regardless of really what this says, your local protocol will dictate a lot of that. Now this first one is going to hopefully will kind of trump that, because this will anytime you are placed at risk, you should not be doing that. So if you're having to climb in a car that has not been cribbed properly or is not stabilized, that's not a good place to do that. If you're having to go into, a building that has a really good chance of coming down, not a good idea. Obviously, in a hostile and aggressive situation, that's not going to be good either. Now, I can tell you as a former flight paramedic, our safety always comes first. So when you were flying and you had somebody code, when you were you are of course paying attention to you're of course paying attention to your patient. But when you're going up and down, which is the most crucial time, all eyes are outside of the aircraft. So you're making sure that your safety is paramount. That patient has now become second, whereas up until that moment, obviously the patient was first. So you don't want to put yourself at risk. Obviously, if there's clinical signs of irreversible death, or you might see it worded as incompatible with life, that's typically not going to be someone you work. So you got several things like rigor mortis or dependent lividity, that pooling of the blood, decapitation, obviously, transection, even decomposition. I mean, that not going to need to work somebody like that. I went on one time where a local fire department was working a code, and every time they did compressions, the legs would kick up because this guy was stiff, so he would, his legs would move up. Every time they pushed down on the chest, it would cause the whole lower body to lift up off the ground. So that was probably a little bit late to be doing CPR. And then a physician order for life-sustaining treatment is not desired. So a valid DNR. You need to make sure that DNR is valid. If there's questions about it, you side on the side of medical care. What you can do at times is if there's some really big questions about it, of course, I suggest calling your medical director. What I like to do in those situations was I would just do BLS and then get a hold of my medical director and see what he wanted me to do. So maybe throw in a BLS airway, don't intubate. I'm not telling you not to, I'm just saying what I would do. Throw in a BLS airway, do compressions, but no meds, no anything, just doing BLS maneuvers. So, management of cardiac arrest. So proceeding with CPR. So if chest compressions were provided before your arrival, proceed with your rhythm analysis. So if the bystanders have delivered uninterrupted chest compressions before your arrival, or if the arrest is witnessed by EMS personnel, you proceed with rhythm analysis. So if compressions have not been provided, or if the arrest was not witnessed by EMS, begin chest compressions while a second rescuer sets up your defibrillator and proceed with rhythm analysis. So really, efforts should focus on creating a low flow state for continuous CPR or a normal flow state by means of defibrillation or other interventions. Remember, the most important thing that we've learned, and if anybody's been around a little bit, you've seen these changes within BLS, is that uninterrupted compressions. So that is really the biggest thing that we can do, is to make sure that we are providing the least amount of interrupted compressions as possible. So a lot of times we talk about what high-quality CPR looks like. That's something that has become kind of a talk within BLS, is high-quality CPR. Much like interrupted compressions is a big kind of buzzword. Within that, high-quality CPR, what does that look like? That's at a rate of 100 to 120 a minute. Obviously, more than 120 a minute, probably not going to be filling up the heart as well as it needs to be. Compressions of the chest to a depth of at least 2 inches. Full chest recoil, that's allowing that heart to refill with blood so we can push that out again. And then a minimal interruption and adequate ventilation, so 2 breaths after 30 compressions. Hang on one sec. All right, so moving on. Remember the 4 possible cardiac arrest rhythms. You have 2 that are shockable and 2 that are not. So you have 2 that are shockable, or pulseless VTAC and pulseless VFib. You guys should be hopefully amazing at recognizing these because everyone passed their EKG final. Asystole is not a shockable rhythm, and then PEA is not a shockable rhythm as well. I'm going to say this, I know that I've said it before, but I'm going to say it again. Remember, PEA is not necessarily a rhythm that you look at on the monitor, but you have to confirm it with lacking mechanical capture or mechanical pulse. So meaning you have pulseless electrical activity, but no mechanical activity, I guess is what I'm trying to say. Key points to remember. So if defib is indicated, the provider giving chest compression should continue while a second rescuer charges the defibrillator. Then pause CPR, clear the patient, deliver the shock, resume compressions immediately. This is some good BLS stuff. So then after 2 minutes or 5 cycles of CPR. Pause efforts, check the rhythm on the monitor. If a rhythm other than VFib or VTAC appears, then identify the new rhythm and check for a pulse. If there is no pulse, then move down the algorithm to the asystole PEA pathway. Remember, that's going to be the non-shockable ones. We had the VFib and VTAC, so what we've talked about here is they were in VFib or VTAC, got busted once. We did 5 cycles of CPR or went on for 2 minutes, did another pulse check or a rhythm check. Now we have something other than VFib or VTAC, so now we're either going to go down asystole or the PEA pathway. Now, if there is a pulse, then we're going to move to the appropriate algorithm for the new rhythm. That's all dependent upon what those rhythms are. Now, if you didn't already understand, which I'm sure you did, but if you didn't understand, now you understand why it's important to understand, to be able to recognize these rhythms. Without recognition of these rhythms, you will not be able to know what your next algorithm is because you're going to go down the wrong one. So don't be that guy or gal that does that. So continuing on, if the rhythm is VFib or VTAC, then resume CPR while charging, clear the patient, and defibrillate. So we want to, one of the things that you see within some bigger services, IMSA's doing it, a lot of the larger services that have ample resources is doing a pit crew method. So you get a lot of people moving in and out of different positions. So what we're talking about is one of the benefits of that is the minimize rescuer fatigue. So because you're doing 2 minutes of good high quality CPR and then you switch and people rotate. Now you have the same person directing the call, but you're able to get several different bodies in there to do CPR and take a little break and move on with something else. So to maximize the number of compressions delivered per minute, interruptions should not exceed 10 seconds. That's a BLS standard. If you've taken a BLS class lately, you actually saw that question. So we're still talking about management using normal saline. We want to get a vascular access. Don't interrupt chest compressions to get an IV. You need to be able to do that without it. And if you are unable to do that without it, with getting an IV, then we're going to move on to IO, right? So we want to be able to achieve vascular access without interrupting chest compressions. So as soon as IV or IO access has been established, we're going to go ahead and give epinephrine. Now here's a good segue into our drug cards. Make sure you know epinephrine. 1 milligram, we're going to be given 1 to 10, right? So give 1 milligram, which is 1 milligram per mil of 1 to 10,000. We're going to give that IV or IO every 3 to 5 minutes to a max of, doesn't matter, right? There is no max. So infinity, let's just say. So till you run out. So, so far we've covered atropine and we're covering epinephrine. Review those drugs. That is one I'm going to insist that you know quite well. So I'm going to insist that you know concentrations and do the math behind it and how does it work and what receptors does it work with and all of that stuff. So then we're going to immediately, just like with any kind of drug, we're going to immediately follow the administration of that medication with some normal saline, and then you can elevate the extremity if you're able to. Now, when you see a point like that, you have to assume that you've got a number of people there. Most of us in services that we work at don't have 5 or 6 bodies where someone can just elevate the arm. Now, I guess you could probably tie some Coband on the wrist and tie it up to that stabilizing bar in the back of the truck or something. But it may not be really a good reality check here to think that someone is going to be able to just hold that up for a couple of minutes. But if you do have that additional body, go ahead and do it. So several options are available for airway management. Bag mask device may be used for adults in cardiac arrest without an advanced airway. We're going to use a 30-to-2 compression to ventilation ratio. Ventilate with just enough volume to produce visible chest rise and deliver each breath over 1 second. Really important key here is it's interesting that we used these adult-sized bags that have such a large tidal volume that is way larger than what an average tidal volume is. I actually saw a small presentation done about ventilation, and these guys were using, I believe it was the pediatric bag, because you were able to empty out the entire bag without overinflating someone's lungs and chancing barotrauma, so, trauma to the respiratory system. So, something to think about, but for whatever reason, we're using these ones that hold like 1,000 mils or whatever, and people typically are having 500 to 600 mils with tidal cup. So, I'm not sure why we do that, but. And make sure that it's nice and slow over 1 second, especially if you have a BLS airway, and need to anyway, so you decrease the chance of barotrauma. But if you have a BLS airway and you're going to chance you're going to chance putting air into the gut versus just putting it all into the lungs. So when inserting an advanced airway, verify placement, secure the tube, deliver 1 breath every 6 seconds. VFib or pulseless V-tach that persists or recurs after 1 or more shocks is called refractory. It's important you remember that, because you'll hear that in the lab, probably hear it out in the field, but you'll definitely see it and hear it in ACLS. So it's important that you understand what that is, and as you see, it's that it persists after 1 or more shocks. So for VFib or V-tach, unresponsive to CPR, defib, and vasopressor therapy, we consider amiodarone or lidocaine. Lidocaine, I don't believe, it may be mentioned in ACLS, but you don't really see it much anymore. It used to be our first line med. Now we've moved on to amiodarone. So that's kind of what we're doing now. But when it's refractory, then sometimes we kind of do a kitchen sink thing where we throw in some other kind of things here. Start marinating that heart up really good. So management of adult cardiac arrest. So one of the big things that we're going to ask you to do is to consider your H's and T's. So you're going to need to review all of that, and I'm going to show you the slide. The very next slide has them listed, but you'll need to pay attention in your book. Table 17-5 is your H's and T's. So whenever you're working a code in the lab, when we're going to say, hey, okay, what's your next step? And you're going to say, I'm going to consider my H's and T's. Well, that's not going to be good enough. You're going to need to start telling us what that means and how you're considering each and every one. Okay, so those are things that we can possibly reverse. Things like hypoxemia. So we can reverse that, right? We can fix hypoxia to an extent. We can get some oxygen on board. Hypovolemia, we can do something about that. So anyways, we'll go over that in just a second, but then, if there is ROSC, assess the vital signs, support the airway and breathing, and give medications as indicated. So here's our H's and T's. You see we've got hypovolemia, hypoxemia, hypothermia. Now, obviously, hyper and hypokalemia, and even hydrogen ions, so your pH, kind of needs to be verified by lab. You just don't probably want to give some potassium just for the heck of it, especially considering we know that it's a big, kind of a strong, powerful electrolyte. But we can do something about pH, right? If you believe that maybe there's a pH issue, probably give a little bicarb or something. So if they've been down a long time and have some acidosis that you believe present, if we're able to overcome with an airway, then you could do some bicarb. Then you move on down to your T's. You got tension pneumo, cardiac tamponade, toxins, and thrombosis. So these are all things that you're going to need to consider, as well as explain to us while you're in the lab of how are you ruling this out. So if you were to say, I'm going to consider my H's and T's, and I say, okay, well, hypovolemia. Well, how are you ruling that out? Well, he does not appear to be dehydrated, doesn't appear to have any gross bleeding, and he's been given 500 mils of fluid. So we can expect that he's had a sufficient volume replacement, right? Hypoxia, well, we have an advanced airway in place. I'm given 100% O2. Pulse ox is this. He pinked up. All those kind of things. Hypothermia, he's not cold. So some of it's not really hard to figure out. It's just you need to know it, and you need to be able to talk your way through it. Because these are all reversible things to an extent. They're reversible. Toxins, well, do we believe that it could be an opioid overdose? So, we could give some Narcan if we believe that it is. So if the local protocol allows, begin a transport when any of the following occurs. If the patient regains a pulse, 6 to 9 shocks have been delivered, so that's a lot of shocks, isn't it? And then the device indicates 3 consecutive messages. So we're talking about, when it says 3 consecutive messages, we're kind of, the way it's reading to me is it's talking about an AED, because it talks about no shock advice. But if you have the same thing when you're given the message, meaning you look at that and you have 3 rhythm analysis of asystole, then that's what we're talking about. So cardiac arrests that require adjustments to procedures include those associated with morbid obesity. So if you haven't ran a morbidly obese full arrest, it's quite an adventure. You know, when you have a 450 to 600 pound person that you're going to try to do compressions on and actually try to compress the heart, and an airway is unimaginable on these people, then you kind of need to know where you go. So in my opinion, this is something you should know about from your medical director and what his expectations are. Because at the end of the day, our safety is very important. And you know, we're just players. I like to say it this way: we're just players in this game. None of this was our fault, and there's no sense in you blowing your back out trying to lift somebody up that had probably 0.00001 chance of coming back. So if you do insist on working them, or your doc insists on you working them, get lots and lots and lots of help, because it's going to be a lot of work. So anyways, morbid obesity, anaphylaxis, obviously it comes with its own little idiosyncrasies. You may end up having to do a surgical correct for someone because of anaphylaxis. Opioids, acute asthma, electrolyte disturbances, a lot of different things. They all present in different ways and present with different challenges. So then post-cardiac arrest. Good job. You guys have saved them. You saved Meemaw, and now we're going to talk about what to do. So begin by optimizing oxygenation and ventilation. And how do we know we're doing a good job there? So we want to assess the breath sounds, right? We want to assess those lung sounds. Make sure we're not wheezing. Make sure they're equal, bilateral, all those things. After ROSC, most patients require some type of ventilatory assistance. So the thing that we want to look for is they get that SpO2 of 90% or higher. One of the things we definitely want to do is avoid hyperventilation. There's not many reasons we need to be hyperventilating anybody anymore. There used to be some thoughts about hyperventilation and head injuries and a lot of different things that we've realized that, we weren't really helping people and we were only hurting them by doing that. So let's quit doing that. And after these, that's why it's nice if you can get these guys on a vent, because it takes over for you. Or if you have, what are they called, rescue pod, it has a nice little blinky light on it every time you should ventilate, because when we do it in our mind and we're a little bit wound up and you got a big old adrenaline dump going on in there, what seems like, every 5 to 6 seconds is really about every 2. So I suggest doing something, whether you've got a counter, whether you've got some timer, or if you're counting out loud. I wouldn't suggest counting out loud, but you know what I'm saying. Find something to help you assure that your rate is correct. Then get your 12 lead as soon as you can. Don't delay care. Don't delay getting to the hospital, but get you a 12 lead when you're able to. Then we want to do a neurological assessment. So assess for signs of hypoperfusion. So, we want to talk about doing a neuro assessment, if you have eye movement, if it's intentional, if they're following you around, and those type of things. So hypotension, we need to correct that pretty rapidly, because the brain will not be adequately perfused if the blood pressure is very low. So somebody comes back and their blood pressure's in the 50s. We need to get some fluid going and try to correct that. Now, the one thing I'll warn you about and caution you about is to think that immediately you're going to throw them on dopamine. Allow the body to try to compensate and fix things. Give it some fluid and see what happens. Don't just immediately start putting dopamine on somebody, because that is an extremely powerful drug. And it's hard to really kind of hone in and do a good job of controlling. Get you a fluid bolus of about 1 to 2 liters. And then if they still have marked hypertension and the transport time to the medical facility will be prolonged, then you can consider, big word, consider administering a vasopressor. So once you've given them 1 to 2 liters, and it's going to be a while, you've got a long transport, then in my opinion, it's okay to consider administering some dopamine. But for me personally, if that we're talking about me, I might call my doc. I'm not sure. But, I'm not a big fan of pushing that stuff on people if they don't necessarily need it. We hope that we're going to see some increase in 1 to 2 liters of fluid and everything. We're going to get them properly fluid resuscitated. But if they need a vasopressor, then they need a vasopressor. Don't be afraid of it. I'm afraid of now. I'm kind of, I hope I'm not trying to make you fearful of it. That's not what I want. So then if the rhythm is bradycardic or tachycardic, we want to follow that same algorithm. So the bradycardia or tachycardia algorithm. Once again, make sure it's not, they could be tachycardic because they need fluid, right? They could be bradycardic because they're hypoxic. Make sure you're treating underlying causes if there is one. So make sure they're properly fluid resuscitated. Make sure they're getting plenty of O2. Make sure that you've given them time to come back up. And then if they're still bradycardic and they have some symptoms, then move on. And then to protect the brain and other organs, you start targeted temperature management after cardiac arrests. So now these are for comatose patients, but that's in the event that you guys do that. And I'm not sure anybody around here is doing that. IMSA was doing that for a while. I don't believe they still are. But what it does is involves maintaining a constant target body temperature between 32 degrees Celsius and 38, or between 89.6 and 100 degrees for at least 24 hours. Trying to cool them down, decrease metabolism, decrease the injury that could have possibly happened, and not increase any injury that's gone on. So the rapid infusion of cold IV fluids was formerly recommended. So in old ACLS, that's what we were doing, was putting cold fluids in people to get them in this targeted hypothermia. That's not any longer being recommended. And we want to closely monitor the post-cardiac patient. Remember, when you get a reperfusion rhythm, so, maybe they had a clot and it caused them to go into cardiac arrest and that clot moved or something, then sometimes that heart is so irritable, you'll see all kinds of wacky rhythms. You can have 2 to 3 separate rhythms in a 6-second strip. So just be prepared and make sure you're taking good care of these people. So when to stop CPR? That's a good question. So the AHA recommends that rescuers continue CPR until effective spontaneous circulation is restored, care is transferred to another team. The rescuer is unable to continue because of exhaustion. So if you're the only one in the back and you got a 35-minute ride, maybe you're not going to be able to continue on. Now, what's really nice is we have a lot of places has these automatic compression devices like the Lucas, and Zoll has one as well. And those are really nice. You don't have to worry about wearing out. You don't have to worry about getting hurt, all of those things. And then criteria indicating irreversible death has been met. So, if we're not seeing changes when we talk about those rhythm changes, all of that. And when a patient does not respond to pre-hospital cardiac arrest, it is acceptable to cease efforts because ALS providers are capable of performing an initial resuscitation equivalent to an in-hospital resuscitation. There's really no benefits to having this done in the ER. So many times people are just hurrying to get to the ER, and I don't know if they think that they're going to get a better job done at the ER, or they just ready to get them out of their truck. But we need to slow down, pay good attention to what we're doing, and carry on and do a good job. All right. Take this quick little break here. All right, guys, picking up. So 12 lead ECGs. People always say, we want to talk about 12 leads. So let's talk about 12 leads. What I'm going to ask you to do is get really good at 3 leads before you worry about 12 lead. But we're going to touch on a few little things here and little pieces of interpretation of 12 leads about specifics. That you'll then later on, when we go into a little bit more of a full-blown 12-lead instructional, these little pieces will be part of the puzzle. So 12-lead is a 12-lead ECG used to localize the cardiac muscle injury site and identify cardiac abnormalities. So what you have to understand here is so when you look at all of those little bitty pictures on a 12 lead, you're seeing basically the same picture just looked at from different angles, okay? So by looking at the heart in multiple ways from multiple angles, you're able to identify the area or region that there is an injury, meaning like an infarction. So and imagine having a picture that's been cut up into 12 different pieces, and that's kind of what you have here with a 12 lead. Is you have that you're all looking at this one picture, but you're looking at it from different angles at little bitty pieces, and it's just one big pie, and with all these different pieces that are part of it. So indications. So when would we do a 12 lead? Well, indications are chest pain or discomfort. So, if you can use it to kind of rule out some chest wall pain or whatever, but, typically you use it when you believe that it's going to be cardiac related chest pain. Now, if you were to put everybody on a 12 lead that had some kind of chest pain, you wouldn't necessarily be wrong for doing that. But, what I'm saying is typically, you want to look at cardiac-related chest pain. So right or left ventricular heart failure, electrolyte imbalance, known or suspected medication overdose, syncope or near syncope, strokes, hemodynamic instability, a lot of different times that we might use them. So monitor mode is used for rhythm interpretation. It's the ECGs, they're recorded in monitor mode, and so what it does is it uses electronic filters to remove the artifact and other unwanted information. Now, what can happen with this is it can also skew the shape and the location of the ST segment and T wave. So there's a lot of different things that can go on. You can see the different capture range, but the thing to remember is that's why we can't just trust our monitor. By knowing that the monitor is set up to read in a particular way, kind of an expected way, then you may have the patient that has something that's off just a little bit, whether it's physically or anatomically, and it's not reading properly, and now you're showing ST elevation when they don't really have ST elevation or whatever. So the whole key is this is a tool to help you diagnose your patient. So this is one little piece of the puzzle to looking at your patient. You need to be mostly concerned with your patient more than you're concerned with the 12 lead. This is going to blow probably somebody's mind here, but we haven't always used 12 leads out in the field. We've been diagnosing MIs in the field for many, many years without 12 leads. And what it is good physical assessment skills. You have somebody that looks like garbage, they have a bad blood pressure, they have a funky looking EKG, just a 3 lead, and they look diaphoretic, they're complaining of chest pain, all of that. Hey, that sounds like they're having an MI. Well, we don't need necessarily a 12 lead to confirm that, but what the 12 lead does is just another tool in our toolbox in figuring this out. So these diagnostic mode filters out very little electrical information. So it's used to record the 12 lead EKG by default. Captures electrical information within the range of 0.5 to 150. I'm not going to go into a lot of this because I'm not going to ask you to put that towards memory. You're welcome to learn all of that if you'd like to. But let's move on to lead placement. The best way to learn is to practice with the equipment. So that's what we'll be doing in class. We're going to practice putting on 12 leads. I'm sure nearly all of you guys put on 12 leads at work. So the best way to learn, like we said, is you just do it. So when positioning the electrodes, make sure your patient does not get chilled, as shivering will cause artifacts. So you want to make sure your patient's not cold, because you get the little body tremors, and next thing you know, you have artifact, you have a messy looking 12 lead. So these two guys are more sensitive. A 12 lead is more sensitive to artifact than 3 leads are. So that's kind of a big deal, you know. So the snapshot, talking about looking at this. So looking at the tracings, 7-step method to 12 lead EKG. Review the snapshot, interpret the dysrhythmia, determine the axis, These are all points that are lined out in your book. Determine the axis, identify conduction system differences, evaluate the chamber size, review for zones of ischemia, injury, and infarction, and then identify non-cardiac causes. So that's what we're talking about within the 12-lead EKG approach. We're going to go over some of this stuff, and we'll do a little bit of a little bit of 12-lead stuff. You're going to be able to identify, the area, the zone of ischemia or injury, infarction. You're going to be able you'll be able to identify some axis deviation, as well as some bundle branch blocks and all of that. And I'm going to be stopping this here in a minute and then create another small video, or two actually, so I can write on the board and show you the way that I want you to look at axis deviation. So hang on a second. Okay, actually that was just a false alarm. Pulled the trigger too early. So we're gonna go on through this. Here what we talked about with dysrhythmia interpretation. Obviously, we already know that. So we're going to go ahead and cover this through here. This is not the way that I do axis determination, but I'm going to cover this, so you may choose to do it this way, and then I'll create the small video that explains kind of, in my opinion, kind of, I don't know, you could call it maybe the white trashy version of axis deviation. So axis, what the axis is. So number one, we're going to read some words like you see up here, QRS axis. A single vector that represents the average of all vectors created by the ventricles during depolarization. I don't really know what that means, or what that even said, to be honest with you. So let me tell you basically what axis is. So basically, axis is the overall direction of ventricular depolarization. So you see where you have some of it depolarizing this way, you have some of it depolarizing this way. This is the overall direction when you look at all of these arrows. This is the way it really should be. And then you have the overall direction of the way everything is depolarizing. So what this does is when we look at axis deviation, it gives you an idea of the way that the heart is depolarizing. There is a couple of things that you do need to remember about axis deviation. I'll remind you again in a little bit, but let me find my note here. So the axis, we're talking about the QRS, so we're talking about the ventricular depolarization, right? That will always move toward hypertrophy and away from infarction. So the way that because there's not going to be much contraction in infarction, right? So it's not going to do any good action out of there. So it moves away from that. And it's dead tissue. Once you have dead tissue, you're not going to be able to continue the pulse, right? And we talked about this being an all or none phenomenon. So let's just go ahead and hit these slides. And then, like I said, I'm going to teach you this other version as well. So when we talk about the axis viewed from lead one, we're talking about this being your QRS, okay? This little, I don't know what you might call this, but this is a QRS. So when it's viewed from lead one, QRS will be positive if heading towards the left arm, and then it will be negative if heading towards the right arm. And you can see here what we're talking about, that the right arm, lead one, you see there, the QRS has a negative deflection, and this has a positive deflection. Now, if we're viewing it from AVF, now remember, lead one is one of your leads on your 12 lead. AVF will be different. So positive if heading toward the feet, if the current is heading toward the feet, and negative if heading toward the head. So when we look here, we see negative deflection. This way, talking about our QRS again. And that is going to be if it's heading towards the head, right? Positive deflection if heading towards the feet. So when we talk about axis, we talk about deviation. I don't do it by this quadrant system, so I can't really teach you the way that this is done. But to determine the QRS, use the quadrant system. The intersection represents the pulse origin. Let me see what I got here. So axis deviation refers to the movement of the QRS axis to the right or the left of its normal position. So What we're talking about is the fastest method to determine QRS axis involves using the QRS complexes in leads 1 and AVF to create a simple quadrant system. The intersection represents the impulse origin with the 4 quadrants where the impulse can travel. So you see that. So positive QRS in leads 1 and AVF are a normal axis. So we have, oh, I see here, we have here, both of them are up. We have that normal. And this is actually similar to the way that I'm going to show you, just mine, I believe, is maybe a little cleaner. It doesn't have a cool little quadrant, but that's okay. And I've got a silly little thing to say that helps you to remember it. So positive QRS in lead 1 and negative in lead AVF. Here we go. Left axis deviation. So what it means we're talking about is you're having more depolarization to the left axis of the heart than normal. And the negative QRS in lead 1, right here, positive, right here, positive QRS in AVF, you have right axis deviation, and then over here, negative in both, you have extreme right axis deviation. So that's kind of what we're talking about with axis deviation. It just happens to be one, like I said, one of the little pieces that we look at when we do a 12 lead. So I'm going to pause this. I'm going to come back on in a second and show you something. That's probably going to blow your mind. No, it's not going to blow your mind, but hang on.